Join our YouTube channel to learn surgery in a simple way. Thyroid papillary carcinoma is managed by either lobectomy or near total, or total thyroidectomy. But what are the factors which will decide extent of thyroid surgery? One factor is whether patient needs radioactive iodine treatment after surgery. And second factor, is there any predisposition to new cancers in residual thyroid gland? Let's see why these factors are important. Thyroid gland is hungry for iodine, and this is true even for radioactive iodine. Papillary thyroid cancer is a differentiated thyroid cancer, meaning that cancer cell retain partial function of tissue of origin, like taking up iodine, producing thyroglobulin, although some functions are lost, like producing thyroid hormones. These radioactive iodine goes inside cancer cells and emits radiation which damages cellular mechanism and DNA, and cancer cell death occurs. But if part or whole of thyroid gland is remaining, then due to sheer size and affinity, it will take majority of radioactive iodine and less radioactive iodine will be available to cancer cells for uptake. This will lead to less concentration of radioactive iodine in cancer cells, hence less effect, so higher dose of radioactive iodine will be required. So, if radioactive iodine is needed in post-operative period, then total, or near total thyroidectomy is done. If patient has received radiation to neck in childhood, due to some other problem or has family history of thyroid cancer, then whole thyroid parenchyma has genetic damage and any part of thyroid parenchyma can give rise to cancer. In such cases, total, or near total thyroidectomy is done to prevent second primary. So, how do we know that patient would need adjuvant radioactive iodine treatment post-surgery? We stratify patient into high-risk or low-risk group, based on tumor features. High-risk group have higher chances that tumor already has metastasized, higher chances of micromets, and higher chances of residual cancer cells after surgery in tumor bed and vicinity. In low-risk group, tumor is most likely confined to thyroid, with little chances of dissemination, hence less need for adjuvant treatment. So won't CT and MRI tell us about presence of distant and nodal metastasis, and help in classifying tumor in high and low risk? Papillary cancer are well-differentiated tumors. They can be missed on CT and MRI. Radioactive iodine scan is more sensitive than CT and MRI for staging. Radioactive iodine scan detects more mets than CT and MRI, so radioactive iodine will do actual staging and risk stratification. If mets are detected on radioactive iodine or case is high risk for micromets, then adjuvant radioactive iodine is needed, for which total or near total thyroidectomy is needed for appropriate dosing. So, how do we stratify patient in high risk, low risk? We use prognostic indicators, like ages, AIMS, MAC-IS, GAMES, TNM and thyroglobulin doubling time. But there is one problem. These indicators use variables which are all not available in pre-op. Like histologic grade is known after post-surgery biopsy, when thyroid with tumor is sent for biopsy. Metastasis and extrathyroidal spread can be accurately known only after radioiodine scan, which is done after total thyroidectomy. Completeness of original surgical resection can be known only after surgery, whether whole thyroid with tumor is completely removed or not. In case of extrathyroidal spread like to trachea or esophagus or to prevertebral fascia, there may be incomplete removal. Similar to mets, there could be cancer cells in nodes which may appear uninvolved in CT and MRI, but they light up on doing radioiodine scan. Thyroglobulin is produced by thyroid tissue and papillary tumor tissue both. So if complete thyroid and tumor is removed, thyroglobulin should be undetectable. If thyroid gland or its portion is remaining, they will produce thyroglobulin and thus, this marker will be of no use. So, how do we decide in pre-op period whether to do lobectomy or near total thyroidectomy? This decision is based on whatever pre-op information is available, irrespective of tumor size. Total or near total thyroidectomy is done in case of distant metastasis, nodal mets, high risk factors like irradiation in childhood and family history and extrathyroidal invasion. These are cases which need radioiodine treatment in post-op and so total, or near thyroidectomy is done. But what if these above factors are absent and disease is limited to thyroid? In intrathyroidal papillary carcinoma, size of tumor plays important role in decision-making. Less than 1 centimeter tumor, with no high-risk features are called papillary microcarcinoma. Treatment have changed nowadays for these tumors which are often detected incidentally. Earlier lobectomy was proposed but active surveillance can also be done. For more than 4 centimeters tumor, total or near total thyroidectomy is done, as there are high chances of micromets to nodes or distally, so radioactive iodine may be needed in post-op. For tumors between 1 to 4 centimeters, lobectomy or total thyroidectomy is advocated. However, most surgeons prefer total thyroidectomy. Why active surveillance in papillary microcarcinoma? Active surveillance means observation without any intervention. Surgery is done when there are signs of disease progression on follow-up ultrasound. But if we are dealing with patients who may not be very compliant for regular follow-up scan, then surgeon may choose to do lobectomy. But if we are choosing lobectomy or active surveillance for papillary microcarcinoma, then we have to be careful that patient has no history of radiation to neck and no family history, to make sure that thyroid tissue left behind is normal. Central group of lymph nodes are level 6 group in neck and extend from hyoid bone to suprasternal notch on both sides of thyroid, and laterally up to carotid. These are essentially podotracheal and podoesophageal nodes, which receive first lymphatics from thyroid. In case of papillary carcinoma thyroid, central group is evaluated by HRUSG and if any node is present FNAC is done. If no nodes are present means an N0 case. We look for factors in which micromets may be present, meaning that few cancer cells may be present in nodes without increasing its size. These are primary thyroid tumor more than 4 centimeters, extracapsular invasion, aggressive cancer variants, BRAF V600E positive thyroid cancer, age less than 45 years, male gender, multifocal tumors. If any feature is present, then central lymph node dissection is done. If any central node is positive or lateral nodes are positive with no central node, then bilateral central group of lymph node dissection is done. This dissection done in node-positive cases is therapeutic lymph node dissection. Dissection done in N0 case is called prophylactic or elective lymph node dissection. If lateral node is positive without central node, still central node is removed, as there could be micromets in them, as they lie midway between thyroid and lateral nodes. Lateral lymph nodes means level 2, 3 and 4. Level 1 and 5 are not removed in thyroid, unless there is heavy bulky nodes in lateral group. In thyroid papillary cancer case, on USG if lateral nodes are not involved, then in N0 cases elective or prophylactic lateral node dissection is not done. If lateral nodes is positive, bilateral central group of lymph node dissection plus ipsilateral lateral lymph node dissection is done. What to do after surgery? Thyroid hormone is essential for life, so, after total thyroidectomy, thyroid hormone supplementation is required for proper body metabolism. Replenish thyroid hormone. But one more purpose of giving thyroid hormone supplementation is there after total thyroidectomy for papillary cancer thyroid. This is to decrease TSH. Papillary Ca is TSH dependent. It needs TSH for growth like growth factor. So by giving hormone, we decrease TSH by feedback inhibition and keep it low. Target TSH range varies with risk stratification. In high-risk cases, target TSH must be less than 0.1 milliunits per milliliter. In intermediate risk, 0.1 to 0.5 milliunits per milliliter. In low risk, 0.5 to 2 milliunits per milliliter. Now after surgery, final risk stratification and staging is done. In low-risk cases, we follow up patient with thyroglobulin levels in serum. If raised, we search for mets, do CT MRI, do completion thyroidectomy and give radioactive iodine. In high-risk cases, there is high risk of residual cancer cells, hence, radioactive iodine ablation is needed, and is also needed in intermediate risk. How is radioiodine ablation and scan is done? Purpose of radioactive iodine scan is to scan whole body for metastasis, eradicate macromets, micromets, residual cancer cells in thyroid beta nodes. Presence of gross residual tumor or mets will need more radioactive iodine while micromets will take up less. How do we decide dose of radioactive iodine? First, in high-risk cases, radioactive iodine is given, and body is scanned for radiation using gamma camera. Disease load is charted and based on uptake. Recommended iodine 131 dose needed to ablate is calculated. This is called dosimetry. Cancer cells need TSH for uptake like normal thyroid tissue, but we lower TSH after surgery to suppress tumor. So, TSH levels are to be increased before scan to increase iodine hunger in cancer cells. There are two ways for that. 1. Withdraw thyroid supplement at least 6 weeks before scan. This will raise TSH, but will also make people hypothyroid for short duration, till hormone is withdrawn. But, in some cases, even temporary hypothyroidism can be risky, like in cardiac cases. In these cases, recombinant TSH injections can be given just before scan. Another problem with scan is that by using radioiodine for scanning, we relieve hunger of tumor cells for iodine. This may reduce effectiveness of radioiodine ablation, which would be done later, after scan, as cancer cells will take up less iodine. This is called stunning. There are 3 ways to prevent stunning. Use radioiodine isotope with short half-life for scan, like iodine 123. We can use low-dose iodine 131 for scan and full dose for ablation. Giving ablative dose within 72 hours of scan has also shown to overcome stunning. Some physicians may skip scan and directly ablate the thyroid with full-dose iodine 131, especially when they have evidence of mets, but due to lack of scan, proper dosimetry is missed. After scan, then ablative dose of iodine 131 is given. Dose is already calculated with dosimetry and it varies with bulk of disease. Once radioiodine ablation is completed, follow-up scan is done after few weeks. This is called post-treatment scanning, and patient is followed up with TSH suppression and thyroglobulin. Join our YouTube channel to learn surgery in a simple way.